Hello everybody, today we are going to talk about the visual quantification for coronary arteries. So far we have discussed the various views for the coronary angiogram and how to identify different views as well as the arteries. I think this talk is very important because this is how you're gonna report what you saw during coronary angiogram, and this is what the other people will be reading about what you have done. So if you have a very good procedural report, that will give a visual idea to the reader as to what you are talking about. So for all these reasons, I think this is a very important talk in terms of visualizing the coronary arteries, but then reporting your findings into a cath report, we call. Okay, with that we come to the figure A here. This is a coronary angiogram, and if you recall, it is probably an RAO caudal view where you have the left circumflex artery going first 3 o'clock and then taking a turn, and probably first going 6 o'clock and then taking a turn toward 3 o'clock, and then an artery that goes 3 o'clock is your LAD. So whenever we are doing an angiogram and we are done, we want to see what are the findings or what are the abnormalities that we have found. And by far the most common thing that we are looking are the lesions or the stenosis. So when it comes to the stenosis, and if you are dictating or writing a cath report, you have to know, and so that you communicate to the reader, where do you find the lesion, how much is the lesion, what the characteristics of the lesion, and things like that. That will make a complete cath report. So in this talk, we'll just start first with the location. That is important because a lesion in a small branch may be medically managed, but a lesion in a main epicardial artery might need more attention. So as we discussed before, if you come to the figure A here, you have this LAD, and I'm just writing this is the proximal segment, and we know that the portion of the LAD before the septal perforator comes off is your proximal LAD, and then you have mid to distal LAD. Similarly, for the circumflex, you can have a proximal circ, which is before this OM branch here, and then you have mid, and then you have a distal. So if you are dictating a lesion, you can tell a lesion was found in the proximal segment of the LAD or the mid segment of the LAD, depending on the location of the lesion. One other thing that you can communicate to the reader is the size of the vessel. Sometimes a lesion might be in the proximal segment of the artery, but the artery might not be very big. So in order to describe that, you have to have a reference value where you can compare the coronary arteries and say if it is a small vessel, it is a medium size vessel, or it is a large vessel. When we are doing coronary angiogram, we can magnify the coronary arteries by changing the magnification or the gain on the II, and everything would look big. But that does not necessarily mean that the coronary arteries are big. So the easiest way to look at that is if you look at picture A here, in the blue I have drawn a catheter. So most of the time we use a 6 French catheter to do a diagnostic coronary angiogram. If you have to convert the French into millimeter, the formula is French divided by pi. So in this case, if a diagnostic catheter, if this diagnostic catheter is 6 French, so you divide 6 by gonna do that, and it's gonna be 2 millimeter. So if you have to round it around the 3.14 to 3, so 6 divided by 3 are 2 millimeter. So for the most part, when you're doing a diagnostic coronary angiogram, this catheter here is about diameter of 2 millimeter. And then you can compare the diameter of the catheter with the coronary arteries. So in this case, if I have to guess, if you look at the catheter, it's probably 2 millimeter or 6 French catheter, and if you look at the proximal circ here, so it's probably around 2.5 or 3.0 vessel. So a vessel which is 3 millimeter to 4 millimeter is probably a medium-sized vessel. A vessel that is less than 3, around like 2.75 or 2.5 is a small vessel, and a large vessels can be somewhere about 4 to 5 millimeter. So this is the easiest way of knowing what the size of the vessel is. So we covered first portion with the first point, which is location of the lesion. It can be the proximal segment, mid segment, distal segment, and then we have also described the size of the vessel, if it is a medium-sized vessel, small-sized vessel, or a large-sized vessel. Next, we move on to the degree of the stenosis. For the most part, in the coronary angiogram, we are more concerned about if the lesion is less than 70%. And that we know from coronary physiology is that if the lesion is more than 70%, that's when it decreases the coronary blood flow and can be significant and might need more intervention or more attention. So with that, I want you to come back to picture A here, and I want you to look at this lesion, circle 1 here. You see a lesion with a bite out of the circumflex, and if you visually look at it, it's probably 50% or less than 50% diameter of that left circumflex artery. And if you see something that goes beyond that, it could be around 70%, 80%, and sometimes you will just see a artery just hanging with a thread. That's probably 80 to 90%. So yes, for all the documentation purposes, we sometimes say 20%, 30%, 40%. But basically what it comes down is a lesion which is more than 70% is what is critical. Below 50% is usually like, your own visual judgment, depending on how much you call the lesion. Next, we come on to the length of the lesion. That will also tell your reader how significant is the lesion. A lesion can be 70% and very focal, let's say 5 millimeter. And even though it's 70%, it might not be significant. But a lesion which can be 70% and it covers about 20 millimeter or 30 millimeter of the coronary artery will be significant because of the length of that lesion. So telling the length of the lesion is also very important, and again is a visual estimation. Once you know your catheter, you know that is 2 millimeter in diameter, and the artery, let's say for example it's a 3 millimeter artery, that you can compare the length of the lesion with that. And you don't have to be accurate when you are calling the length of the lesion. One important thing is, while you are doing an angiogram and calling a lesion, you have to see the healthy artery in order to have a reference in terms of how much the stenosis is. For example, in this lesion 1, we saw that we call it like a 50%, but if you see proximal artery, that was healthy, and then the distal artery is also very smooth and plump. So you can easily compare the healthy segment with the disease or the stenotic lesion and call it. But sometimes you might not be able to see a proximal healthy or a normal artery. For that, I want you to look at this lesion 3 here, which is in the LAD. So it starts as a left main, and then you start to see an LAD which is diffusely diseased. So now you cannot tell what's the size of the LAD unless you look at the distal segment. So here in the mid LAD you see that the artery is a medium-sized artery, not a small one. So although you don't have a proximal segment to compare, but you can still see the distal segment in patients who have a diffuse coronary artery disease. With that, we move on to the point 4, which is a type of the lesion. ACC/AHA classifies the lesions that you are calling depending on how much calcification, the length, and the site, as well as the angulation. So if you are looking at a lesion, you can call it a type A lesion, type B lesion, type C lesion. Again, this is going to help your fellow cardiologists and the colleagues who are reading your cath report, like what kind of lesion that you are looking at. A type A lesion is a lesion which is short, less than 10 millimeter. There's not much of angulation of the artery. There are no side branches. It's smooth. There might not be that much of a calcification, and it's not in the ostial segment. So exactly the lesion that we talking about here, if you come back to picture A, is 2. Here you see it's more than 50%, somewhere close to 70%, and then it is in the body. It's not more than 10 millimeter in length, and you don't see a lot of calcification there. Then we come to the type B lesions, which are 10 to 20 millimeter long. They can have calcification. They might involve the ostium. They are diffuse disease, and for that I want you to look at lesion 3 here. Here you see that it involves the ostial LAD. It's probably around 10 to 20 millimeter, and there is some calcification, but it's not involving any side branches or anything that you might be concerned about. Last but not the least is the type C lesion, which is a diffusely diseased. There are side branches that might be involved, and if you stent that lesion, you might lose the side branches. So for that, I want you to look at this lesion 4 in the LAD. See how long the lesion is, probably 30 millimeter. There is diffuse disease, calcification, eccentric plaque, and you see a side branch that's coming off. And most probably if you put a stent in here, you might jeopardize the side branch. So that constitutes the type C lesions. With that, we come to the point 5, which is a flow. Very easy. If you look at the dye flowing through the coronary artery, 0 is when you don't have any flow going past the lesion. It could be a lesion which is 100%, could be a chronic occlusion, maybe a acute thrombotic occlusion or a plaque rupture. And then you have TIMI 3 flow, which is a brisk flow. So anything in between TIMI 0 flow or TIMI 3 is a sluggish flow. So depending on how you see the dye flowing through the coronary artery, you can call them. And last but not the least is the appearance, and this is a section that we will cover separately. We have to describe the lesion as if it is a calcified, which probably be more chronic. If it is thrombotic, can be a clot there. There might be some dissection. In female patient, young patient, pregnant ladies, we see what we call like a spontaneous coronary artery dissection. So that would be another thing that you can put in your report for the sake of completion. So I hope this was helpful. Do let me know if you have any questions. This concludes our coronary angiogram images as well as the lesions. Have a good day.